Sandra is a 52-year-old female who has been experiencing symptoms of depression. She reported to her naturopathic doctor that her mood has been really low and often has trouble getting to sleep at night. She is concerned she might be depressed. According to the DSM, depression is characterized by at least 5 of the following 9 symptoms: a depressed mood, inability to feel pleasure, sleep disturbances, change in weight or appetite, psychomotor problems, lack of energy, poor concentration, feelings of worthlessness or guilt, suicidal ideation, and often these symptoms can be incredibly intense. Depression screening tools such as the PHQ-9 and PHQ-2 or the Hamilton Depression Score can be used to help doctors rule in or out depression. In Sandra's case, her doctor diagnosed her with major depressive disorder. Although the cause is still unknown, depression can be characterized as a complex relationship between any or all of the following: biological alteration, psychosocial factors, familial patterns of shared genetics or environments, environmental exposures, chronic stress, diet, or medications.
Conventional treatment for depression largely involves the use of second-generation antidepressant drugs as first-line therapy. Second-generation antidepressants include SSRIs, SNRIs, and tetracyclic antidepressants. All second-generation antidepressants are considered equally as effective. Therefore, in choosing which specific pharmacological agent to prescribe to the patient, several factors are considered. These include cost, patient preference, and side effects. Side effects, particularly nausea and vomiting, are the main reasons patients discontinue this form of treatment. Other potential side effects include diarrhea, dizziness, dry mouth, fatigue, headache, sexual dysfunction, sweating, tremor, and weight gain. Clinical guidelines suggest a treatment duration of 4 to 12 months. It has been shown that over half of patients treated with SSRIs or tricyclic antidepressants discontinue treatment after 6 weeks. Factors contributing to the shortened treatment duration are thought to be fear of social stigma and concerns over side effects of these medications.
EPA, DHA, and ALA have been hypothesized to play a role in maintaining cell membrane fluidity, regulating neurotransmitters, and suppressing cytokine production. In the Western diet, omega-6 fatty acids and their precursors are much more abundant than omega-3 fatty acids and their precursors. A high omega-6 to omega-3 ratio can alter cell membrane properties and increase production of inflammatory mediators. This is caused because arachidonic acid, an omega-6 fatty acid found in cell membranes, is a precursor of inflammatory mediators such as prostaglandins and thromboxanes. By contrast, omega-3 fatty acids are anti-inflammatory. Therefore, a high dietary omega-6 to omega-3 fatty ratio could promote neuroinflammation. Increased omega-3 fatty acid concentration in the diet may also act by altering CNS cell membrane fluidity and phospholipid composition, which may alter the structure and function of the proteins embedded in it. By this mechanism, increased omega-3 fatty acid concentrations in cell membranes have been shown to affect serotonin and dopamine neurotransmission.
It has been estimated that 60 to 75% of suicide cases are due to poorly treated mood disorders. As described previously, there are many concerns surrounding the conventional treatment for depression, and many patients do not complete the recommended course of pharmacological treatment. This has sparked interest in alternative options in the treatment of depression. In more recent years, research has been conducted on whether omega-3 fatty acids, particularly EPA and DHA, reduces suicide mortality in depressed patients. The authors of a recently published study utilized dietary assessment data from 3 large American cohort studies to estimate the association between omega-3 and omega-6 PUFA intake and the incidence of suicide mortality over the course of a 14 to 22-year follow-up period. The study included over 205,000 participants. Cause of death was analyzed via review of the death certificate by a blinded physician. The authors concluded that there was no evidence to support the hypothesis that omega-3 fatty acids or fish intake reduced the suicide mortality rate among depressed participants. The study had several limitations, including exclusion of people under the age of 29 and confounding factors of higher levels of physical activity and lower rates of smoking among the groups consuming higher amounts of EPA and DHA. The authors also discussed the possibility that the doses weren't high enough to show an effect in these studies. Mean EPA and DHA intake in the uppermost quartile of intake ranged from 0.34 to 0.51 grams per day, and the 95th percentile of daily intake ranged from 0.46 to 0.82 grams per day. In studies on omega-3 fatty acid supplementation, the dose often well exceeds 1 gram per day. It is clear more research on this topic is needed. At this time, we do not recommend the use of omega-3 fatty acids in the treatment of Sandra's depression. More high-quality research is needed in this area before it can be concluded that omega-3s are an appropriate intervention for depressed patients. It is important for everyone to include omega-3 fatty acids in their health regime in some form, in an ideal dose of 1 to 2 grams per day. If obtaining omega-3s from food sources, it is recommended to consume foods high in omega-3s at least twice per week. Potential food sources include white fish, salmon, sardines, anchovies, and flax seeds. It may also be necessary for some people to supplement with an omega-3 containing capsule based on their individual diet. We recommend more high-quality research in this area exploring the effects of omega-3 supplementation on suicide mortality and the dose-response relationship in depressed patients taking omega-3s.